So, interstitial lung disease can be due to known causes or it may be idiopathic. Some known causes are sarcoid, some vasculitis can cause it, such as granulomatosis with polyangiitis, infective causes such as fungal or tuberculosis or viral pneumonias, environmental causes like silicosis or hypersensitivity pneumonitis, connective tissue diseases like lupus or scleroderma. And there's also those idiopathic causes such as idiopathic pulmonary fibrosis, but they all have similar clinical presentations. They have progressive exertional dyspnea and also a dry cough. So more than 50% of these patients have a significant smoking history, and on exam you can hear fine inspiratory crackles, or on exam you can also see on their fingertips digital clubbing. Remember that the diagnosis itself is based off clinical presentation, pulmonary function testing, and also radiographic imaging. The type of radiographic imaging that you would see on chest x-ray, for example, would show reticular or nodular interstitial opacities, and on high-resolution chest CT, you can see fibrosis, some honeycombing, or even traction bronchiectasis. If the diagnosis remains pretty unclear, despite having all the radiographic imaging, the pulmonary function testing, and the clinical features, it's important to get a lung biopsy for further assessment. If there's no environmental, infectious, or autoimmune etiology that is found, then idiopathic pulmonary fibrosis is the most likely clinical diagnosis. What basically happens in idiopathic pulmonary fibrosis is excessive collagen deposition in the extracellular matrix around the alveoli. This naturally causes a decrease in diffusion capacity across the alveolar capillary membrane, which naturally increases the alveolar arterial oxygen gradient, and this causes hypoxemia in the patient. Because you have scarring and fibrosis, the total lung capacity is obviously going to be diminished. This also means the functional residual capacity inside the lungs and the residual volume inside the lungs is also going to be decreased. Because you have fibrosis, you want to think of it as a loss of elasticity, so the recoil in the lungs is also diminished, and you have this restrictive pattern seen on pulmonary function testing. If you make this connection with a restrictive pattern and a balloon losing its elasticity, the FEV1 and the FVC are going to be decreased. And this is depicted with the ratio of FEV1 over the FVC, or the forced vital capacity, which is the total amount of air exhaled through the FEV1 test, is decreased much more than the FEV1. The ratios will appear either normal or even increased. Like I mentioned earlier, patients with interstitial lung disease are more likely to have hypoxemia, but in very late stages, you can even have hypercapnia. This is because carbon dioxide diffuses much faster through the capillary membranes than oxygen. But also remember, in obstructive, not restrictive, but in obstructive lung disease like in emphysema, there's air trapping that will occur in these patients with emphysema, and they are more likely to have hypercapnia compared to interstitial lung disease.